Let me share my screen. I will start. Can you all see the screen?
Yes, sir, we can see.
Okay, so let us see about handling a case with subfertility. Okay, right. Now it's very important when you have a patient presented you with subfertility, be able to, this is a very common case at your exams, and you should be able to really take a proper history and discuss the case in such a way that it reflects that your knowledge on fertility issues. Now when you okay, I'm not going to deal a lot on this, and usually subfertility, if you have a patient presenting to you, we initiate some kind of investigation generally after at least 1 year of regular unprotected sexual intercourse. Okay, especially if they are young, right? But if they are old patients, then we may think of investigating them earlier, maybe about 6 months or so. However, if there are any patients who have married and already have certain negative factors for fertility, like having previous laparotomies, previous endometriosis, or any kind of pelvic infection, then we may also think of investigating them early. Okay, so that's something you have to keep in mind. Now, when you take a history from a patient with subfertility, it's very important to find out. The patient might say, I have been married for 5 years and I don't have a child. Okay? But the important thing is for you to, now you have to find out when a patient comes to you with subfertility, you might have to find out whether she's actually subfertile. Okay? So just because she's married for 4 years or 5 years does not mean they have tried for a pregnancy. So that you must ask them, okay, have you tried for a pregnancy? For how long? You married for 5 years, but I've been trying for a pregnancy for 1 year maybe. Okay, and also, also you must find out whether she has been exposed adequately for a pregnancy. From this, I mean, if the patient is in Colombo and husband is in Mana or somewhere, and then you find people are meeting so infrequently, and then you may find that their exposure to fertility might be very much less. Okay, so that's something you must be able to see and clarify from these patients. And then it's also important to find out, we come to sexual history in detail, but when I say adequate exposure, you also must find out whether there will be sexual difficulties. Okay, they may be trying, but maybe they have either the woman or the male partner have sexual difficulties and maybe not having adequate exposure in terms of having penetration. And then very important to find out their menstrual history. Okay, because the thing is, now when you say menstrual history, the people might have very regular cycles, or people might have very irregular cycles. If somebody is having periods once in 3 months, you know very likely that she will ovulate once in 3 months also. Whereas if somebody has regular 28-day cycles, then it's a different thing. She probably ovulate every month. So that is very important to find out, because then if you want to say, very important to find out if the cycles are especially irregular, ask them whether the cycles, what is the shortest cycle and what is the longest cycle, so that you know what the kind of a range that the cycle varies. And this is very important to counsel them with regard to the fertile period. Okay, you know, always a woman ovulates 14 days prior to her next period. So supposing she has a period today, then we know she has ovulated 2 weeks before. Okay. So that's why we need to, then you will be able to advise looking at her menstrual calendar for about 6 months or so. In addition to that, find out whether they have other menstrual symptoms like dysmenorrhea, which might indicate some pathology. Okay. Then you also need to find out certain system reviews related to fertility, especially having thyroid disease, maybe somebody irregular cycles, kind of galacteria, like PCOS having hirsutism, having things like menstrual symptoms, dyspareunia, right? So look at some relevant things. Don't go on asking all. There's no point asking, right, whether you have breathing difficulties and all, right? That's a different issue. This is not related to fertility. You need to find out what are the important things that are relevant to a woman who is subfertile, especially with regard to endocrine, whether there's a problem. Then routine looking at their gynecological and medical histories are important, especially go into detail, because the thing is, when you are taking a woman with subfertility, when you are taking medical and surgical and gynecological history, you are looking at two things. One, you are looking at, okay, can I treat this patient for fertility, and is she suitable to get pregnant? Supposing she has when we discussed cases earlier, if you have severe pulmonary hypertension, then you know there's a problem. You should not be going on treating fertility for this patient if she has primary pulmonary hypertension. So you are looking at medical surgical history to see two things. One, is she fit to get pregnant? Two, are there any medical problems or are there any surgical problems that could interfere or have a negative impact on fertility? And in this case, especially things like any sexually transmitted diseases, any previous history of gynecological surgery, having had things like thyroid disorders, those are relevant, important things. On the other hand, to see whether she's fit to get pregnant, looking at things like uncontrolled diabetes, looking at things like sort of heart disease are important, right? So your history has to fulfill those things as well. And then okay. Yes, then looking at the other important thing is, especially when you talk about past history and when you have a patient coming to you, now there's a lot, there may be history related to her management up to that point. When I say that, what I'm meaning is a patient might come and tell you, okay, I have been married for 6 years, I've been trying for 3 years, but over the 3 years, she may have had some treatment or she must have undergone certain investigations. So you must go into the details about, if you are seeing her today, up to the point that you are meeting, you have met her, what kind of treatment, what kind of investigations have been done so far. And that is very important, because if she has had ovulation induction done 5 years for the last 1 year, and then she had 7 times intrauterine inseminations done, then there's no point you doing the same thing, because then you know, okay, all these have been done. Now I must go beyond that. Okay, so because of that, what has treatment she has had so far becomes very, very important. Then similarly, you need to get a sort of an obstetric history. When I say obstetric history, sometimes the patients also you have to be very careful. Patients comes and say, okay, I was pregnant for 4 times, but I miscarried. Okay, that's not obstetric, that's part of gynae, but importantly, has she had pregnancies before? That's what I'm going to say. Patients will come and tell you that, okay, I had 4 times I miscarried or something. But the thing is, you have to look at whether those are pregnancies that are proven to be pregnant. For some people, just missing a period for 2 weeks, they might assume that they are pregnant. But you must see, has she had a pregnancy test done, or has she had an early ultrasound scan to say, confirm that they were pregnant at that. So that is again important, because we classify, and you say primary or secondary subfertility, we need to know whether those pregnancies that she is talking about are they actual pregnancies. Okay, so go into details about it. And I told you earlier about the importance of sexual history, because you need to find out whether she has any sexual dysfunctions. So let know whether she has any the frequency of coitus. As I said, people may be in different sort of parts of the country. So because sometimes it may be just a matter of sorting out that sexual difficulty for her to get pregnant, and no point sort of doing all this treatment and giving so many drugs if they can't have sexual intercourse. Okay, you need to address that. And look at if they have been sort of been trying using some family planning so far. Go into details about what kind of family planning has she had. Okay, because sometimes you know, there are a lot of women who might be practicing sort of a calendar method or some traditional methods of family planning. Okay, but when you ask, are you have you used family planning, they might say no, because they imagine that what you're asking is about either the pill or the condom or the intrauterine device. But you must ask, okay, I've been trying to say, okay, did you look at the sort of days of the month, the calendar month, and avoid pregnancy during a certain period of time? So that kind of questions has to be asked, because the patients otherwise may not come out with the answers that you want unless the questions are very specific, and then you ask them. Okay? And also you need to find out their drug history, about what drugs they have been using in terms of fertility, in terms of other cases, whether you have been using any drugs as well. Okay. Then looking at a family history, you may need to find out what kind of familial problems that they have. Because there are certain things like fibroids, endometriosis, and things like that can be sometimes familial. Okay, so look at it. Also important to find out, especially if you are treating, whether there is a family history of any genetic diseases. Okay, it's very important. Just one second. So very important for you to find out whether there is any family history of any disorders for you to get into these difficulties. Okay, and also important to find out. Yeah, hello. Yeah. Are you the student who called me? For this time only you can, I will fix a different time, but I can't give, I mean, there's no way that you are going to get any other times, right? You might have to do it in another group, right? But if you are in Candy, you can't come, no, but next, you are not, remember, you are not allowed to go home just because the group is divided to two groups, right? Yeah. Right, okay. Then when you go to their personal and sort of social history, uh, again, remember why you are asking social history. Okay, because now when you take social history, why you ask social history from a subfertile couple is different to why you ask social history from a person who has a malignancy. Okay, because a subfertile couple, you don't know why are there any social problems that sort of situations where she might not be able to get pregnant. Okay, so in terms of that, you must find out what employment is she doing. Are they living together? Uh, what kind of habits will they have, husband have, smoking, alcohol, because some of this can sort of have an impact on your sperm counts and fertility. Uh, kind of maybe the income kind of may be relevant, because if you are talking about affording fertility treatment, because all the things are not available in the government sector, that also may be important. Supposing somebody has had 2 surgeries for endometriosis, had undergone 6-7 cycles of IUI, now she's 35 years, then you might think, okay, is she a candidate who can go up to a higher level of treatment like assisted reproduction? And also, there's no point telling somebody to go for that if you can't afford it. Okay, so that's again something you need to bring out in your histories. Okay? The next important thing is, of course, when you these are again just a summary of what we have been doing, but again then your examination becomes important. Okay, so you very important. What I have done is I have just highlighted the important areas that you might need to take in the history. When you come to examination, so look at what uh, uh, important things that you can look in her general examination that is relevant to fertility. Okay, especially her BMI may be relevant. If she's a patient who's sort of 110 kilos of weight, then of course they need to think of reducing their weights. Okay. Then in patients, if they have any kind of other menstrual problems, there may be markers of a certain pathology or certain genetic disorders you might find on a general examination. Somebody who's got sort of, for example, if somebody comes to you who's totally primary amenorrheic, are there markers of Turner's? Okay. Are there markers of androgen resistance? Okay. So, okay, you need to find out if their cycles are irregular. Is she obese? Okay, is she obese, or if she has any other problem with fertility, you need to find out. Okay, so things like androgen excess, hirsutism, features of hyperthyroidism, all that are relevant. Right? When you come to, of course, your cardiovascular system and respiratory system examinations are important. You need to just make sure they are fit. Then when you come to abdominal examination, you must look at whether there's an abdominal pathology in terms of having, maybe she's having uterine fibroids, maybe having ovarian cyst, endometriosis. So you must look for any kind of abdominal pathology in terms of having lumps, okay? Or in terms of having tenderness and maybe certain pelvic infections. Okay? So what I'm trying to say is you need to think, okay, what are the reasons on my abdominal examination that can be relevant to a patient not getting pregnant? Okay, so that's the kind of thing you must keep in your mind. Okay. Then when you come to local examination, obviously you need to look for any kind of congenital anomalies. There may be people who have this thing. You must look at the development of secondary sexual characteristics. Okay. And then when you come to the speculum examination, look at whether any cervical polyps and things. And when you do a bimanual pelvic examination, look for any uterine and ovarian pathology. So you're looking at uterine size, uterine enlargement, mobility of the uterus, okay? And of course, then you are looking at any kind of adnexal masses on the left and the right adnexa. Then you need to look at also feel the pouch of Douglas and for any nodulars, nodularity in the pouch of Douglas, because that might indicate that she has rectovaginal septum endometriosis. So you need to look at this and comment on whether you make any have any findings. Okay, because that and also these findings you should be able to correlate with the your history. Suppose if somebody has severe dysmenorrhea, then what kind of dysmenorrhea does she have? Is it primary or secondary dysmenorrhea? Maybe if it's secondary dysmenorrhea, does your pelvic examination showing some certain abnormalities in terms of examination having breaches, so that might suggest endometriosis, you must bring out and you will be able to explain their symptoms with your clinical findings. So those are important to do. Then you may also need to look at the male partner depending on the situation. Okay, you may not be able to go through all sort of examinations. Very important. For example, if they come with a seminal fluid analysis, which is totally normal, then you may not need to go through a lot of things unless she has sexual difficulties or sexual erectile dysfunctions or things like that. But if they come with a seminal fluid count which is subnormal, then you may also have to look at whether there's a reason for an abnormal or low sperm count in terms of having primary or secondary testicular failure, or maybe due to certain drugs. So you need to, male partner is also important because equally important. So you need to ask at least a few questions with regard to the male partner, especially if they have an abnormal seminal fluid count. Okay, when you once you have done the initial history and examination, then you need to do the certain investigations. Okay. The two important thing is, of course, you need to, as a primary investigation, you need to do a seminal analysis, making sure they abstain for a period from about 3 to 7 days, and do a proper collection and do a seminal fluid analysis. Okay, and of course to see whether those parameters are normal. When you're looking at, you are not looking at the count, you're looking at the count, you're looking at motility, you're looking at morphology, and you're looking at any other infections as well. Then you must document whether they are having normal ovulation. Now, ovulation, as I told you earlier, you need to do normal ovulatory functions has to be documented. We'll come to that in a minute, especially if a patient has regular menstrual cycles, if he has premenstrual symptoms, if you have mid-cycle spotting, then if she has kind of a primary dysmenorrhea, and all that means probably she is in the history also, you can say, think of somebody very likely to have ovulatory cycles, okay, depending on her symptoms and the regulatory cycles. Okay, we come to that in a minute. And also the next thing is you must also, your investigations also should document the tubal and the uterine status in terms of having tubal patency and your uterine, whether there's a normal uterus. And your also investigations also will be directed to looking for ovarian reserve. When I say ovarian reserve, you know, anybody is born with certain number of eggs in their ovaries, and with advancing age, the number of eggs that are in the ovaries gets less. So you must see whether she has an adequate number of eggs left in the ovaries for you to start certain kind of treatment. So that will mainly will be related to the age. But in addition to age, if the patient has repeated side of surgery, then that also may be relevant, because every time you remove ovarian cyst, every time you do surgery in the ovaries, you are going to reduce their ovarian reserve. Okay, so that's again something. Okay, so when you come to semen analysis, so these are the important aspects of investigations. Looking at the male, looking at ovulation, looking at the tubal patency and the uterine and abnormality, looking at ovarian reserve. So those are aspects that you need to look at. So as I told you, semen analysis, you need to do collected after 2 to 7 days of abstinence and look at what the counts are, whether they are normal. Then when you look at the ovarian function, there are many ways that you can look at the ovarian function, whether they are ovulatory or not. As I told you, it can be done in the history. Okay, having regular cycles, premenstrual symptoms, primary dysmenorrhea, mid-cycle spotting, and all that will indicate that she is this. Then you can do certain tests also to see whether there's ovulatory cycles are occurring. Especially you can do a mid-luteal phase serum progesterone level, or some people earlier used to do endometrial biopsies, but very hard. No one really does endometrial biopsies these days. But important thing about doing this day 21 progesterone level, this day 21 progesterone level doesn't fit to all menstrual cycles. Day 21 is for day 28 day cycles. That is something that people really not paying attention to. So if you do a day 21 progesterone in day 28 day cycles, that means 1 week prior to her next period. Okay. Similarly, if you have a 35 day cycles, there's no point doing day 21 progesterone, because at that time they won't ovulate. So in that cycle, you must do 1 week prior to her next period. So that means if a 35 day cycle there, you must do on day 28. Okay, and that is how you must interpret. Now you can't do a day 21 progesterone level in a 35 day cycle and say you are not ovulating. Okay, so that's, keep that in mind. Okay, so as I told, you can do similarly you can do a endometrial sampling if you wish to. And then of course there are certain ways that you can predict ovulation using LH kits. Okay, you can use LH kits to predict ovulation by looking for the LH surge, and then you can also look at ovulation by doing the ultrasound scans, because you know when you have a mature follicle, the mature follicle is about 18 to 20 millimeters in size, and even if you repeat the scan later, you can see whether the follicle is ruptured and then whether she has ovulated. Okay, so there are clinically you can do the history, you can suspect that she is ovulating. Then there are certain urine tests you can do like LH kit. You can do blood tests. Okay, you can do ultrasound scan. Right, so all these has to put together and see whether she is actually ovulating. Okay, and then I said you need to look at tubal patencies. Okay, now not put slides there, but when you are looking at the tubal patency, you are basically doing looking at there are, you can do a hysterosalpingogram, Of course, that might be the primary investigation in cases who have been married for a short period of time. Then you have options to laparoscopy and a dye test combined with a hysteroscopy or not. Okay. Then there are other methods of assessing the tubal functions like ultrasound guided injection of certain fluids. Okay, histosonograms, which you mean. Okay. Anyway, whatever it is, you may need to select the investigation for tubal patency. Now, when you select the tubal investigation for tubal patency, you must consider a lot of factors. You must consider their age. You must consider the possible suspected pathology. You must consider your other investigation findings like ultrasound scans. When I say that, for example, if a young couple with no other abnormality, you don't suspect anything, you just want a tubal patency, you can do a hysterosalpingogram. But if you have a patient coming to you, she's complaining of severe dysmenorrhea and she's sort of abdominal pain all the time, then rather than doing hysterosalpingogram, it's better for you to do a laparoscopy and dye test, because then you are looking for more information, not only the tubal patency, you're looking for evidence of endometriosis, you're looking for evidence of pelvic infections, you're looking for adhesions, everything. So that you have to decide, select the investigation depending on the patient's symptoms, depending on what you are actually looking for in these patients. Okay? So that's also very important. Okay? Then we talk about the ovarian reserve. Now, ovarian reserve, I told what ovarian reserve is, but when you have to do assess the ovarian reserve, there are so many tests to do, but most commonly used test to assess ovarian reserve is doing a day 3 FSH level, because we know that around day 3, early part of the follicular phase, the FSH levels will be low. If you look at the pattern of hormone rise in the menstrual cycle. Another test you can do is what's called anti-Mullerian hormone levels, and this is a hormone that is secreted by the antral follicles, and depending on the antral follicle count and then hormone levels, you can assess the ovarian reserve. The other test is for you to do an ultrasound scan in the early follicular phase and do what's called an antral follicle count. Okay, you can count the follicles, which are for about 4 to 8 millimeters in size, and the number of follicles, and depending on that, you will decide, okay, how many antral follicles are there in the ovaries which might respond to your treatment, and these are important, especially if you are going for some kind of a ovulation inductions with parenteral drugs, especially gonadotropins, because especially the amount of the dose that you take and the amount of the monitoring you do, all will depend on this kind of thing, because if you have a very high AMH or antral follicle count and an antibody hormone level, then you know that's a very likely that they might hyperstimulate for your treatment, so that you can adjust the dose with that. Okay? So these 3 are very important: day 3 FSH, antral follicle count, and ultrasound scan to do. Day 3 FSH, antibody hormone levels, and an ultrasound scan to do the antral follicle count. So with those you can assess the ovarian reserve. Okay. These are the rough. You don't have to go detail, but very likely if you have a very high AMH level, that will indicate that very possibility of higher ovarian hyperstimulation. And then when you have a low AMH level, then they are having a poor ovarian reserve, and they may not respond to your treatment as you would expect in this situation. Okay, so that's important for you to understand. And then So this is what I told you about antral follicle count. There are 2 to 10 millimeter follicles in the early follicular phase. If the counts are low, generally we say less than 7 would say the response is poor. Okay. Right, then when you assess these patients this way, then you're looking at how to manage these patients with problems with fertility. Now, what level of treatment you would start for these patients will depend on what the problems they have. If a couple who is young, married for 6 months, 9 months, comes to your treatment for your advice and saying that they are subfertile, then you need not go into extensive investigation straight away. So it may be a very basic thing you do at that point. Take their histories properly, do a proper examination. And if you find an abnormality, obviously you need to manage that abnormality. If the investigation shows that she's got PCO, if the investigation shows she's got thyroid disease, then all those have to be treated. But otherwise, you just need to see whether you can give simple advice to say whether she get pregnant. So, education, looking at negative factors that might interfere with fertility. Okay? Giving some education about the need of be aware about the fertile period, right? The importance of coital frequency, see whether they are living apart and then they are sort of not having adequate exposure for pregnancy. Look at whether they have any coital difficulties. From this, what you are looking at is in the basic level treatment, you are trying to correct the factors which may not providing the optimal exposure to a pregnancy. And also, you are also trying to correct the simple factors that may have a negative impact on fertility, like smoking. Sometimes their occupation, you must look at. Some people, you know, the high temperatures, if they're working at a very high exposure to sunlight and all, you might have a low sperm count. Okay, so those are things that you must look at, of course. Even SFA, familial dialysis, is a very important primary level of investigation. Okay? So if you have treated them, okay, you advise them, you give them sort of basic treatment, and then if they don't respond to this, they don't get pregnant, then you go to the next level of treatment. Okay. Next level of treatment might mean you use certain ovulation induction drugs. This is you may or may not do a tubal patency assessment initially, or you might decide to treat them for about 3-4 months, and if they don't get pregnant, to go for a tubal patency test. But if they don't get pregnant, then you can go to ovulation induction. Okay. This is done with different drugs. You have clomiphene, you have different aromatase inhibitors, then you can use gonadotropins, and metformin is not a drug to be used in to induce ovulation, but of course, if you are obese and if you are very high, if you suspect high insulin resistance, you may use, but not as a routine drug to give for all these patients who are subfertile. Because you find sometimes people are given metformin for no reason. Sometimes they have regular cycles and everything, but they are just little sort of obese, and still they are put on metformin, not even with the normal blood sugar. So you must justify whatever the drug that you use, you must justify, and you must know whether what result you are going to expect from the drug. That is one of the biggest problems. People prescribe various things for these subfertile couples, not knowing, they also don't know why they are giving it. Okay. So that's why your drugs list for these patients are very restricted and limited, not giving all sorts of vitamins, all sorts of things, and saying giving false hopes to patients. So look at the problem. When you give a medication, look at what result you are going to expect from the drug that you give, and give it. Okay. So especially when you come to second level treatment, of course, you are just purposing using the ovulation induction drugs. Okay. especially we know, especially for patients who have irregular cycles, probably aromatase inhibitors like letrozole might be a drug, first line drug rather than using chloroquine. That's most of the guidelines which suggested. And once you have done the that, sometimes if you do response to oral drugs, you can go to injectable gonadotrophins. But as I told you earlier, if you are giving gonadotrophins, you must know the likely response and the kind of start the lower dose. There are different regimes. You don't have to know. The step up and step down protocols for ovulation inductions are there. But don't worry about those. But importantly, if you are doing gonadotrophins, it's very important to monitor them. Okay. And for patients who are anovulatory, there's a very sort of a limited place. I must say it's a very limited place for ovarian drilling to be done in these patients who don't respond to normal ovulation induction. Now, a little word about ovarian drilling, just because, and you might be seeing these patients are being, ovarian drilling has been done in patients who they have regular cycles, no other comorbidity, and nothing, and they just see the ovarian, they just drill, right? So you should never do that. To be honest with you, I have not done ovarian drilling for the last maybe 10 years uh, because you have to be careful, because every time you do drilling, you are happily burning the ovary, and every time you burn the ovary, you are destroying the follicles. Okay, so you have to be careful, right? Because once you destroy and burn them, because just because you put the diatemy in one place, there is a lot of burning around that diatemy, and all these follicles will get destroyed. So you have to very be cautious and think many times before you do a drilling. And certainly, there's no place for repeat drilling. You find some people also now drilling done once is now still anovulatory, and they get drilling done twice, and you do that twice, and then you make her to have ovarian failure. Then there's no point doing anything. You have drilled everything, and of course now you have made a subfertile by uh, sort of reducing the ovarian reserve, and then you have done the damage. So by that time you can't correct it. Okay? And then you know that patients, when you use ovulation induction drugs, you must know why they are not ovulating. Okay, you know there are three categories of ovarian failure. It can be a hypothalamic cause, like hypogonadotrophic hypergonadism, where the hormone levels be low. You might be having these common ones, nomogonadotrophic, nomoestrogenic people. The bigger group is this. This is where the people like polycystic ovaries come. And of course, third group with anovulation might be people who had primary ovarian failure. So you must, before using drugs, then you must know why she is not ovulating. Is it due to hypothalamic cause? Is it due to just a normal person with normal gonadotrophin levels, or is she got a primary ovarian failure? Okay, so because the drugs you use, if she has primary ovarian failure, whatever the drug you use, you are not going to get anything. If you have hypothalamic problem, then your medication is to give supply the FSH that is required for follicular maturation. And people with hyperprolactinemia, where your treatment might be bromocriptine, is classified in a different group. Okay, so these are different classes. And also, as I told you, if you are doing any kind of ovulation induction, it's very important to monitor. And the monitoring is very often done with transvaginal scans. As I told you earlier, you might do certain things like day 21 progesterone. Some people are doing it, and you might use LH kits to assess predict ovulation. So we told you the list of sort of tests that you can do to predict ovulation. Okay? So whatever it is, it's very important you use follicular monitoring in these patients, and then only you know what the response to drugs are. So once you use ovulation induction, then you can give a trigger to ovulate, like HCG injections, and then you can either ask them to have timed intercourse or think of doing intrauterine inseminations. Especially intrauterine inseminations are useful for people who have sexual difficulties, people who have suboptimal seminal fluid analysis reports. Okay, especially with high immotile counts, then you might be able to prepare and remove those immotile sperms and they take the best one. So there are general two methods that are being used for sperm preparation. One is called the swim up method. Another one is called the density gradient method. So whatever the method you use, you can prepare the sperms and do a intrauterine insemination. Okay? So these are used, basically you deposit the sperms in the upper part of the uterus. Okay. Then you can come to, if you have certainly have failed treatment with primary and second level treatment, then you can think of going to tertiary level treatment. Okay, and also you might straight away go to advanced fertility treatment in certain cases like severe male factor subfertility. In cases like severe male factor subfertility, or people with sort of bilateral tubal obstruction. Then you can think of people with severe endometriosis who treatment has failed. If you have failed treatment for infertility, unexplained infertility, then people with things like other possible problems, like maybe they have had chemotherapy for malignancies, maybe they've had people had ovarian surgery, ovarian failures. So if you have these kind of situation, then there's a requirement for donor sperms or donor eggs, where you might have to think of going for advanced fertility treatment. Okay. So similar problems will be there for ICSI or IVF. Okay. And then basically what you do in assisted reproduction is you these are the basic thing you do. Okay. You do a pituitary down ligation, then you use drugs to hyperstimulate the ovaries. You collect the eggs and then collect the sperms, mix them in the laboratory, fertilize, produce an embryo and put it in the uterine cavity. And that's what the basic steps of assisted reproduction is. Of course, this is not the steps for everything. We might change the steps depending on certain patients, certain sort of certain situations. Because now this is the classical, what you called, what I have shown is a classical, what's called a long protocol, but you use what's called a different protocols, like using agonist or you can use antagonist, but don't worry about what protocols you use. You just need to know the basic concept of what is being done. Okay. So for this, as I told you, there are different protocols you can use. Okay. And whatever the protocol you use, it's very important you monitor them. Okay. So you monitor and you look at the follicles that have been developed, and then you will be aspirating those follicles that are there. This is what the aspiration needles looks like. I mean, I have probably shown you in earlier also. And then what you do is you aspirate the follicles. You just need to, you can do it under local anesthetic. Once you have hyperstimulated the ovaries, you are going to aspirate the eggs. Okay. So egg aspiration is done by just by puncturing the follicles using an aspiration needle, and you puncture and then you aspirate these fluid in the ovarian follicle and see whether you have collected the eggs. Okay. So that fluid that you have collected will go to the lab, and then you can have a look and see whether those are collected properly. Right. And then, of course, when we go to the lab, you look at in the lab and collect all those eggs. Okay. These are the sort of follicles that you have aspirated, right? And then you, from every tube that you collect those eggs and see Okay, so what you see are the eggs that have been collected. Okay, and then you take the sperm sample and of course then get the egg and inject in the spirit. Then when you want the sperms, and usually you collect the sperms by masturbation. If the sperm counts are good, then obtain a sample. If your sperm sample is azoospermic and there are no sperms or absolutely low level sperms, then you might be able to recover the sperms from the testes. So what you do is you can either get sperm from aspirating the, especially if there's a case of obstructive azoospermia, then you might be, if there's obstruction here, you might be able to aspirate sperms from the epididymis. Or sometimes you might be get the sperm from the testes. If it's a primary testicular failure, then again, although you might say it's primary testicular failure, sometimes you might be able to recover few sperms from the testes. Okay, so you either do a percutaneous aspiration, and then once you take it and have a look under the microscope to see whether you have collected the sperms. Or you can do a true cut biopsy of from the testes. You can do a aspiration, or you can do open testicular biopsy and then look at the sperm. So whatever it is, you are trying different methods to get sperms from the testes. Okay, okay, and then once you now I said you I showed you how to collect the eggs. You hyperstimulate the ovaries, collect the number of eggs you can get. You generally you can get more eggs, like 5, 10, 20 even, sometimes 40, 50 even you can get. And then once you get the sperm sample, you fertilize. Okay. Now this, if you have adequate number of sperms, then you can use just put the sperms around the egg and just let it to fertilize using conventional IVF, because out of these sperms that are around you see, just one sperm will enter and fertilize the eggs. Generally, you incubate about 30,000 sperms, or if the sperm count is very low and you have very low count, then you need to inject the sperm into the egg under the microscope. Okay, so you're looking at the microscope, and then you can inject the sperms into the egg. Okay. Right. So once you do that, then you produce embryos. Okay. Then you find, once you have put the sperm and egg together, it will start dividing day 2, day 3, day 4. When this is about the day 3 embryos, you get about 8 cells embryos around this stage. Okay. Okay. Or sometimes you can continue growing it in the laboratory until about the blastocyst stage. Whatever it is, once you have done either day 3 or day 5 blastocyst stage embryos, you replace into the uterine cavity. You replace, generally at any given time, you replace 1 or 2 embryos, because you don't replace 5 embryos, because you need to avoid multiple pregnancies as well. So you don't need to put so many embryos and have triplets, quadruplets and all. Because then the problems comes with prematurity, neonatal death, everything. So you need to know, generally most of the countries would advocate single embryo transfer, or maximum, if they are older patients, they would say, okay, you can put 2 embryos. Okay, so that's what you need to practice. And then you replace those embryos into the uterine cavity. So once you have fertilized, and in the laboratory, when you say you fertilize it in one of these dishes, and then you take it into this trans catheter, and then you take it and transfer into the uterine cavity. Okay, so that's what you do there. and you transfer it to the uterine cavity. Hopefully they'll get pregnant. Okay. Now I told you earlier, when you have excess embryos, you can always freeze them. Okay. Because if you have aspirated 10 eggs, you have 10 embryos, you replace 2 and the other 8 you can freeze them. Okay. And freeze them, and subsequently you can take them out and transfer later on into the uterine cavity and get pregnant. Okay. Then there are situations where you might not be able to recover any sperms from the male partner when you have to think of going for donor sperms. Okay. If you are using donor sperms for various indications, and these are not the only list of investigations, very important for you to have a donor sperm bank. Sperm bank, right? Because the thing is, if you just take donor sperms from anybody who's walking in the streets, if you take donor sperms from anybody who's walking on the streets, then the problem is you might transmit certain infections like hepatitis, HIV, and all to these patients. So you have to just imagine if a woman has 10 intrauterine inseminations done from donors, and if you don't screen them, 10 donors means 10 men. Okay. So if you don't screen them, you are exposing that woman to risk of HIV, hepatitis from 10 people. Okay. It's like having sex with 10 people. Okay. So you have to be very, very careful not to just take sperms from somebody and put it with the uterine cavity of a woman. You have to screen them, then you have to store them. After the window period, check them again, and then only use the sperms. So that's why the sperm banks are important. Okay. And also you must also understand, from a sperm bank, you have a limited number of pregnancies you can create. Certain other countries have laws. UK says maximum 15 pregnancies. Obviously, as usual, this country doesn't have any law. But of course, you have to have self-imposed laws. So we do restrict, we say maximum 5. Okay, but only thing we don't know whether she go to another place and give to another 5. Okay. You can simply see the difference. If somebody use somebody's sperms and produce 200 pregnancies, so those 200 pregnancies, babies or offsprings are carrying the same genetic material of that man. You can imagine if you do this in Borella, get one of you and to donate sperms and then produce 500 pregnancies. You can see there can be males, females, and there can be intermarriages also. People with same genetic material will get married also. Okay. So this is why very important to have regulations. Okay. About what you can do. Okay. So this is what you bank the sperms. Okay. Similarly, you may have to, if the woman has problems, you might go for oocyte donation. Okay. It may be in a case of primary ovarian failure if the patient has had prior oophorectomies, cases of Turner syndrome, and everything. You might have to go for egg donation as well. Okay. Now, of course, you can even think of freezing eggs in these patients. Okay. Sometimes if the patient has, you can go for full donation, or sometimes you might even get people to share their eggs. Suppose you have a young couple who's 28 years who comes to treatment, and you have another 45-year-old woman who may not have any eggs. If this young person is prepared to say, okay, if I produce 20 eggs, I will keep 10 and I'll donate 10. That is what the egg sharing means. Okay, you can think of egg sharing. And then similarly, you can go for treatment. And if sometimes in situations where the people have lost uterus and maybe even person who's had hysterectomy, you can think of using surrogacy. Okay. Sometimes you not only oocytes, sometimes you also donate embryos also. Because what happens is, once you have people have gone for IVF and if they have produced a lot of embryos, once they get pregnant, they have 1 or 2 children, they might say, okay, I don't want need to keep the rest of it. You can say take and donate those to people who are subfertile. Okay, so that's again, if both male and female partner having problems, then you have a probably looking at embryo transfers. Okay. Okay, surrogacy is of course hiring somebody to the uterus to carry a pregnancy. This is done in cases where there is severe uterine pathology. Okay. Okay. So, just to know, you should be aware. I mean, I don't want you to all know the minor details, but you should be aware of different options of treatment for this subfertile couple that is available. Because otherwise, it's unfair by the people, because you just keep on doing the same thing until they are old enough not to get pregnant. Okay. So, if you have any questions, yes, I'm prepared to answer. Do you have any questions?
Sir, how long should we wait after primary treatment, like advices to the newly married couple to start on secondary level treatment?
It's like this. You probably maximum. Supposing you have that will sometimes be different, but suppose you have a couple who is 25 years of age, married just for 6 months, 1 year, then you might go on for about a couple of months, maybe 5, 6 months of that. Otherwise, most of us would say maximum try for a period of 6 months. And in a young couple, if you don't get pregnant, go to the next level of treatment. Okay. But if they are 35 years, then you don't go give that kind of long period. I would say if you don't get pregnant in 3, 4 months, come back. Okay. Uh, so likewise, it might vary, but perhaps maximum I would say, if you are giving this thing, give about 6 months for them to try. That's in a young couple with no pelvic pathology, normal sperm counts, and everything else. Okay.
Okay, sir, thank you.
Anything else? Yeah. Any more questions? Right. If there are no questions, we can then end.